My name is Brittney Crawford and I am a kindergarten teacher, and my job is super busy, super active. So it requires me to be constantly moving. I'm standing on my feet all day. I'm up at the front of the room. I'm down on the floor at the back of the room. So it's exhausting, and especially with lipedema, because I'll come home from work, my feet are throbbing, my legs are full feeling, just really uncomfortable and very sore and very tired. I'm here to share my story and to help spread awareness about this disease so that maybe I can help even just one woman. Back around the time probably of puberty, when my body was starting to change and develop, I noticed that my top half was a different size than my bottom half. And my legs became very heavy, very tree trunk-like. This kind of continued on. I got married, and with the hormonal changes in my life with each child that I had, it began to get worse. There were certain things that I noticed. When I would sit down on the floor to play with my kids, my legs were so tender that if my children pushed on them or leaned on them, it hurt really bad, and it just seemed unusual. I also noticed a lot of bruises that I would have, and I never knew why. I never knew how the bruises got there. I didn't know what was causing them. They just felt really heavy when I would go to move around, and they became really painful. This continued on until about maybe 2 years ago when I went into early menopause. And then the symptoms that I had been noticing before just amped up. They increased. I also noticed that I was starting to gain weight. It didn't matter what diet I tried. I've tried so many. It didn't matter what exercise I tried. The weight would not come off. Psychologically too, it was really damaging. I just was beside myself. I could hardly dress myself. I had such a poor body image because I was so heavy down below and so much smaller on top. And then I started noticing too, within the last couple of years, that it was moving into my arms. And not so much this part, but this top part of my arms began to get really heavy. Throughout the years, I kept trying to research with my husband. He was noticing how my legs were getting worse and how they were changing. And I visited so many different kinds of doctors trying to figure out what was wrong.
I started doing research online, and when I would look at lymphedema and I would look at the description, I go, that's not Brittney, that's not the situation. It doesn't seem to match up quite right. Some of the symptoms are similar. Eventually, I found lipedema. When I read the descriptions, I knew immediately that this was it.
Not many people have heard of this disease. A lot of doctors have never heard of this disease. And I felt like I was having to advocate for myself to try to find the right doctor to try to figure out what this was. And so I have visited multiple doctors. And so I just kept meeting dead end after dead end. And it was heartbreaking and frustrating. I'd come home in tears from these doctors' offices, just feeling like there was no hope. And then that started to change when I had a conversation with my primary care doctor, and she was amazing. She has wonderful bedside manner, and she actually listened to me and believed me and advocated for me. And then from her recommendation, I was able to go see a therapist to get the MLD, the manual lymphatic drainage massage, and that made a difference. I woke up after going to therapy the first time. I woke up the next morning and I had ankles for the first time. So I was running around the house telling my whole family, I have ankles, because I hadn't seen them in so long. And so those visits timed out with insurance. And from there, I was able to get my Flexitouch machine. That was a turning point for me, because having that machine allowed me to do my own therapy in my own home. We need to get awareness out about this disease. Women need help. They need to be heard. women who look like me, who is smaller on the top than the bottom, who has painful legs that are tender and sore to the touch, who has bruising and swelling. Please help. We need help with this disease.
Welcome, everyone, to Lipedema Basics for Vascular Specialists. I'm Tony Gasparis, a vascular surgeon from Stony Brook Medicine, and actually the current president for the American Venous Forum. And I want to thank Tactile for putting this program together, and I want to thank an all-star team that we have put together for this program. Actually, all of them are recently involved in the recent publication on the standard of care for lipedema in the U.S., which was just published in Phlebology. Our first speaker is going to be Karen Herbst. Karen is from the Total Lipedema Care in Beverly Hills, California. And she'll be talking to us about lipedema in your practice. Following Karen, Steve Dean out of Ohio State University is going to be talking about no edema in lipedema. And finally, Paula Donahue is going to give us a discussion on lipedema therapy out of physical medicine rehab in Vanderbilt. So let's get started. And Karen, if you can go ahead and share your slides. As you're doing that, I want to remind everybody, anybody has any questions during this, please put it down in the Q&A box at the bottom there. I know there's going to be a lot of questions. We have a big group today, a lot of interest in this topic. And we'll try to answer as many as we can during this presentation, as well as at the end of the presentation during the discussion time. So go ahead, Karen.
Thank you so much. It's a pleasure to be here. Thank you to everyone at Tactile Medical for making this possible. And it's such a great privilege to be on with Steve Dean and Paula Donahue, all members of the Standard of Care Committee for Lipedema in the US. So I am going to talk to the vascular specialists and the phlebologists out there about how you can help women with lipedema in your practice. These are my disclosures. So I would like you to, when you see a woman coming into your practice who has obvious venous disease, to ask whether she has lipedema or not, especially if she has that kind of two-body syndrome that we heard Brittney talk about, smaller on the top, larger on the bottom. And you may see a woman who has obvious venous disease, but this is obviously an extreme representation of lipedema legs. This woman has not only lipedema and venous disease, but also lymphedema. But when you're looking at the legs and you see signs of vascular disease, you should also look at the legs and see if you see signs of lipedema. So how often do we see vein disease in lipedema? So there are two papers that showed that about 25% of women with lipedema have venous disease. They didn't say what kind, whether it was just varicose veins. I'm assuming they meant something treatable like chronic venous insufficiency, but it wasn't clear. In a paper by Child et al., they found that 39.5% of women with lipedema had varicose veins and 53% had other signs of venous disease. And then the best study of them all by Dr. Stephen Dean found that 50% of women with lipedema and lipolymphedema have chronic venous insufficiency. So a good portion of women with lipedema have venous disease. And we know that we need more research in this area to figure out what kind of venous disease that they have. And I think that you would be great to help with that. So lipedema is often confused with lymphedema, and they have some similarities. Both can have an onset at the time of puberty. You can find tissue fibrosis in both. When the tissue becomes affected, especially when it becomes fibrotic, in lymphedema, it becomes not diet responsive. And lipedema tissue, by definition, is not diet responsive. In fact, women with lipedema find it hard to lose weight from diet, exercise, or even bariatric surgery. They both can have an increase in fat growth in affected areas. Females are more often affected. It can be symmetric, even in lymphedema, although we often think of lymphedema as asymmetric. They both have edema. They both can complain of heavy limbs and aching limbs. The defect in lymphedema is usually one of lymphatic vessels primarily, so damage to the lymphatic vessels or malformation of the lymphatic vessels. In lipedema, it's likely a multifactorial pathophysiology, and we think that more than one gene is responsible for quite a large number of variations that we see in the lipedema phenotype. In lymphedema, the skin becomes thicker and firmer. In lipedema, you'll find normal skin to thin skin, except in areas of fibrosis, usually at the bottom of the leg, around the cuff area above the ankle. In lymphedema, you're going to often see edema of the hands or feet unless they're very well controlled and they're wearing tight shoes or gauntlets. In lipedema, the hands and feet are generally unaffected unless obesity is also present, so non-lipedema obesity, or perhaps hypermobile joints. Obesity is variable in lymphedema, where it's very common in lipedema. Tissue pitting is common in lymphedema, and non-pitting edema is present in lipedema, although you can also see pitting edema. Lymphedema occurs in males and females, whereas lipedema is primarily in females. Lymphedema can be asymmetric. Lipedema is usually symmetric. If it is asymmetric, then you should be looking for something else going on at the same time. Onset can be at any age in lymphedema. It can be variable in lipedema occurring at puberty, pregnancy, or menopause. The tissue in lipedema is very tender to palpation, and there's severe pain. And in fact, if you use a short form 36 questionnaire for quality of life, it can distinguish between lipedema and lymphedema in terms of pain. Women with lipedema tend to have higher levels of pain and pain daily. We do stage lipedema, and we also stage lymphedema. Stage 0 lymphedema is when the limb feels achy or heavy, but you really don't see any signs of swelling. Stage 1 is when edema can develop, but it resolves with elevation or sleeping overnight. In stage 2, the edema does not reverse after elevation or sleeping overnight. And in stage 3, it's a severe stage with lipofibrosis and other signs. I've added a stage 0 for lipedema. So the feeling of an achy, heavy limb prior to the development of lipedema, I don't know if we know that for sure, but it certainly makes sense that there would be a prodromal stage in lipedema as well. And many women complain of growing pains in their legs around the time of puberty that can continue beyond the puberty stage. In stage 1 lipedema, the skin's going to be very smooth, but if you palpate it with your hands, you're going to feel small nodules throughout the tissue, and the fat tissue is increased. Again, on the limbs, usually the lower body and the arms, sparing the trunk. In stage 2, the skin becomes indented and there's larger nodules, meaning there's a lot more fibrosis within the tissue. And in stage 3, there are lobules of skin and the underlying fat tissue, which we call loose connective tissue. And we know that women with lipedema seek care from vascular surgeons and phlebologists. And the reason for this is that the symptoms of lipedema and chronic venous disease overlap. Both can have leg pain and achiness. Both can have swelling, fatigue, a feeling of heaviness in the legs, itching, restless legs, and night cramps. An advancing age, female gender, and higher BMI compound this underlying relationship between lipedema and chronic venous disease.
Karen, given the fact that the symptoms for lipedema are similar to venous disease, how can you differentiate if somebody does have varicose veins and the physical signs of lipedema, and as far as patient expectations, if you're going to treat their venous disease, what do you tell them as far as symptom relief?
Yeah, so I have a slide on that. Do you mind if I get to that?
Sure.
So if you suspect that a patient who comes to see you has lipedema, there are certain signs that you want to look for. You want to look for that body disparity, that larger lower body than the trunk, that two-body syndrome, and the waist to hip ratio is much less than 0.85. Anything 0.85 and above is consistent with abdominal obesity. The tissue is symmetric on both sides, as you can see in this picture, and there are cups or bulges of tissue around the joints, for example, the ankles, the knees, the elbows, and the wrists. And that, as I mentioned, there are palpable tissue nodules on the legs and the arms, and the tissue is usually tender to palpation, and you'll hear stories from the women about how their cat will walk on their thighs and it's excruciatingly painful. The hands and feet are usually not affected, so the Stemmer sign is going to be negative on the hands and feet, unlike that you would find in lymphedema. So once you suspect that your patient has lipedema and you've found some of the signs and symptoms, what are some of the questions you want to ask your patient? So this is a list of some good questions and those answers. So when did your lipedema tissue first appear? Or you can ask, when did you notice you had larger legs, hips, and buttocks? And their answer is usually puberty, pregnancy, menopause, and other times of weight gain. You can also ask them, did your lipedema worsen after any surgery? And we don't have a lot of data on this, but we hear this a lot, that a woman may have already had lipedema but didn't know it. And when she had surgery, for example, a hysterectomy, that her lipedema appeared so that it was recognizable. You also want to ask them, when you lose weight, which parts of the body can you lose it from? And women with lipedema can usually lose fat from the head, the trunk, the abdomen, although not always from the abdomen. And sometimes the fat can be lost globally if there's also lifestyle-induced obesity present. But most often, women will say, I lose it from my head, my trunk, and not my arms and legs. You also want to ask if there's a family history of lipedema on the mother or father's side. And for 60% or more women with lipedema, there is a family history. You also want to ask, do they have venous disease, especially venous insufficiency? Because it's my opinion that venous disease, especially inflammatory venous disease, can exacerbate lipedema. And we also think that microvascular disease may also be important in the pathophysiology of lipedema. And finally, you can ask them, do you bruise easily? And the answer is invariably yes. So now you've identified your patient with lipedema, you've asked appropriate history questions. Well, what do you do for them? Well, I think because venous disease is so common in lipedema that a venous duplex ultrasound should be a common test in lipedema. But there are some other imaging that can be done. There are a number of papers in the literature talking about ultrasound of lipedema tissue, but so far nothing has been accepted for clinical use or clinical diagnosis. Magnetic resonance imaging is expensive, but you can definitely see if there is fluid within the tissue by MRI. And a paper found by MRI lymphography that there was edema in the lipedema tissue without the usual honeycomb appearance that you find in lymphedema. And finally, there's nuclear medicine lymphangioscintigraphy scan. This is a go-to exam if you want to determine whether your patient has any lymphatic abnormalities. And lymphatic flow is usually sluggish, even in early stages of lipedema. And you do want to order this test when there's asymmetry of the legs in lipedema, or you suspect that there's lymphedema, where documentation could help in their treatment. Some facilities perform this exam well and others do not. I know Steve Dean has a really good facility, and I suspect that Paula Donahue does as well at Vanderbilt. So vein treatment of lipedema, Tony, this is what you asked me. So there are no data on whether treatment of chronic venous insufficiency helps or worsens lipedema tissue and symptoms. But a goal of treatment, of course, is to improve discomfort. So you want to give reasonable expectations for CVI treatment outcomes, including that the overall leg shape, that the edema and underlying symptoms from lipedema most likely will not improve after your treatment. But by removing the CVI component, people can expect an overall net improvement of end-of-day symptoms. And in the long run, our hope is that there may be a reduction in the progression of lipedema. When you're going to...
So Karen, are you saying that the thought is that chronic venous deficiency contributes to the progression of lipedema, or?
Yeah, I think it contributes to the progression of a lipedema in some of the patients with lipedema. I won't say all, because not all of my patients with lipedema have even varicose veins, much less chronic venous insufficiency. But chronic venous insufficiency is an inflammatory disorder. Lipedema is an inflammatory disorder. When you add them together, plus you overload the lymphatic system with fluid from the chronic venous insufficiency, I believe that the lipedema does worsen.
Mm-hmm.
So if you're going to use thermal ablation, we had some recommendations that we put forth in our standard of care paper. So we know that the lymphatic vessels are altered in lipedema. Obviously, they're sluggish in flow on a lymphangioscintigraphy, but there may be other abnormalities on the microvascular level. So when you use thermal ablation to treat CVI in the proximal saphenous vein segments, we suggest you use generous perivascular tumescent anesthesia to infiltrate around the veins, especially at the saphenofemoral and saphenopopliteal junctions. And this is to increase protection of the surrounding lymphatics. And the decision to treat distal saphenous segments or large tributaries of CVI must be individualized. Again, there's no data.
Now, one of the questions in the audience is, how about use of venoactive drugs, which are used sometimes for venous disease? Have you tried that for lipedema? And
yes. Yep. So all therapies for venous disease have been used in patients with lipedema. I think what's most important is to do what you feel most comfortable with and do what you have expertise in. And again, there's some phlebologists who are treating even the really small, tiny veins that are dilated in lipedema. We do think that there's a microvascular disease. We do think that the venules are contributing excess fluid to the interstitial space in lipedema, but we just don't have the data. And so I think you just have to use your expertise to make the decisions on exactly what to treat and what to use. But I've seen everything used and everything seems to work pretty well.
Because, when you look at the number or the percentage of the prevalence of venous disease in the lipedema population, the three papers you mentioned earlier, with the highest being Steve's numbers of 50%. I mean, those are similar numbers of the general population of venous disease, 30 to 50%. Steve, what's your feeling as far as the association? Is it really just because of the prevalence of venous disease that you see it in the lipedema population, or is there a different prevalence in the lipedema population? Unmute yourself. Yeah, sorry.
Yeah, here. Tony, can I say I have a slide that actually will address that question?
What did I look at? Wow, I can foresee things, I guess.
Yeah. Well, can we circle back to that?
Sure. Yeah.
Okay. Thank you.
There's a couple of questions on this from the audience. That's why I'm.
Oh, okay.
That's okay. We'll touch it base later.
And we're not saying that chronic venous insufficiency causes lipedema. I just want to be clear on that.
Yeah. No.
Because there's so much venous disease, that would mean that there be a much larger numbers of people with lipedema, including men. But what we're saying is that there's a lot of different things that could exacerbate the development of lipedema, could make it worse.
I mean, the most important thing so far for the audience, I think, is the fact that the clinical symptoms can be very similar.
Yes.
And when you're treating these patients' venous disease, you have to really, set patient expectations as far as symptom improvement.
Correct. Yeah, there are some women who say that they received benefit after treatment, and there's some that say they didn't. There's some that say they developed more swelling after treatment. There's some that say their swelling is better. So we're missing a lot of data.
Karen, I'll just interject. It's interesting in the patients I've seen that have had improvement, it always tends to be short-lived. I've never had a patient say it's long-standing. I felt better for 6 months or so, and they go back to their baseline. That's just been my anecdotal experience.
I mean, the key thing is if you can really separate what symptoms are venous and what are secondary to lipedema. If you can differentiate the two by your history and physical, that's where I think you may be able to help some patients.
Yep. And I think when you have if you have more pain in one leg versus another, and you can correlate that to chronic venous insufficiency, that's certainly a reason to treat. Okay. So I mentioned that there may be microvascular disease and lipedema. And we have identified that there's an increase in blood vessel formation, so angiogenesis in lipedema tissue, as well as dilated microvessels. And from an older paper by Curry and Merlin, they found that there was increased capillary permeability and venule permeability in lipedema. And this was followed by fibrosis with the formation of macronodules with lipofibrosis. And that resulted in what's called a leopard skin distribution of hot and cold zones that can be seen on thermography. And this is a patient of mine that shows just that. So you can see she's got the classic lipedema leg. She's got fat that completely covers the entire front of her leg, including over her knee and the calf. And you can see the cuff. And then you can see the normal foot. So it's just a perfect picture of lipedema. And then you can see this leopard skin distribution of hot and cold zones. And I don't see this in everybody. Mostly what I see when I use thermography is the veins, the dilated veins, but this was just classic. So I think an accurate diagnosis of lipedema can improve a person's mental well-being. You can be a hero for your patient if you actually diagnose your patient with lipedema when they did not know it before. And it also increases the opportunity for treatment. Treatment options that Paula is going to talk about a little bit more include compression garments, sequential pneumatic compression pumps like the Flexitouch Plus, a diet to stabilize weight and improve tissue health, exercise to improve the muscle strength and the endogenous lymph pump, medications, supplements, manual and instrument-assisted therapies, and lipedema reduction surgery. And these are all described in our standard of care paper. So in conclusion, people with lipedema often go undiagnosed for years, sometimes 20, 40 years. And many struggle with symptoms they don't understand, and they have psychosocial stress. And I think as a vascular specialist, a phlebologist, as a therapist, you can make a huge difference in the lives of patients by accurately diagnosing lipedema and other comorbidities, including lymphedema and venous disease. And your expertise can help a person with lipedema get the care they need to increase their quality of life.
Thank you, Karen. You can stop sharing. And a couple of follow-up questions. Do you observe Raynaud's disease commonly in patients, in lipedema patients?
I do. A number of my patients have Raynaud's. They also have acrocyanosis. And every time I find a patient with acrocyanosis, I take a picture and I send it to Steve. So, and we think that at least the acrocyanosis part, which is that darkening, ruddy, bluish, reddish hue, especially of the feet, but also of the hands, has an association with hypermobile joints or hypermobile tissue.
All right. And can you go a little bit more into the pathophysiology of lipedema?
You know, we really don't understand the pathophysiology of lipedema right now. I did mention microvascular disease. So we think there is an angiopathy, but it's kind of like the chicken and the egg. There's some people that believe that the abnormal fat tissue forms first, which causes a disturbance in blood vessels and lymphatics. There's others that think that the lymphatics are disturbed first, causing fluid to back up and then fat to grow. So I think in the future, we will get more research to help us better understand that. And I think Paul is going to talk about it a little bit more, and so is Steve.
All right. So, Steve, why don't you tell us why there's no edema in lipedema?
Well, I will just tell you what's out there now, Tony, and that you can see my title here, and I've put a question mark after the title, and we're going to discuss this. Here's my disclosure, and so let's take you all the way back to 1951 when Drs. Wold and colleagues at the Mayo Clinic released their seminal article on lipedema, and they had the 6 following cardinal features which define lipedema. And I would draw your attention to the component of minimal pitting edema. So that's what I've always seen I've just seen edema in my patients. I'll leave it at that. So I was surprised where I don't know how many of you have read this document. The International Consensus document was released in the Journal of Wound Care in November of 2020 last year. And it was entitled Lipedema, a Paradigm Shift in Consensus. And they started right off with the following stunning protestation, that there is no edema in lipedema. Stunning, like I said. And let me just point out there that the authors are only referencing patients with pure lipedema. And how do we define a pure lipedema patient? That would be a lipedema patient without foot swelling, without lymphedema, without chronic venous insufficiency, much more likely to involve a stage 1 patient, less likely stage 2, and very unlikely to involve a stage 3 patient. These are 2 great examples of a pure lipedema patient. So let me ask you the question, which lipedema cohort do you think is most likely to have pure lipedema? Well, as I said, it's a stage 1, and it's a patient that's less likely to be obese. And in fact, here are all comments from the International Consensus document. Of the 2,344 women diagnosed with lipedema at the Authors Lymphology Clinic, only 3% were of normal weight. 88% were obese. In this Polish study, 80% were obese, 50% were actually morbidly obese. And in this British study, 4% of the lipedema patients were of normal body weight. That's it, 4%, 85% were obese. So the authors rightly concluded that, in short, a lipedema patient of normal weight is a rarity. And so therefore, a pure lipedema patient, I would submit to you, is somewhat of a rarity. Now let's go back and address the issue at hand, that there is no edema in lipedema. I mean, you want to know what evidence did the authors use to support this interesting protestation? Well, first of all, they start right off and they show you 2 examples of lipedema patients where they obtained an ultrasound of the thighs of the lipedema patients, and they're showing absence of edema. I thought that was rather curious, and I just thought that was interesting. If you were going to show edema, why would you use the thighs, right? I mean, what's the most likely anatomic distribution of a leg to manifest edema? It's going to be the mid and distal portions of the calf, but yet they chose to show you thighs with absence of edema. So I thought that was rather curious. And in fact, I would have been more convinced if they would have showed me a stage 3 or a type 3 patient, that is a full limb type of lipedema patient that involves swelling all the way down to the ankle. And then they showed an absence of edema. I may be a little bit more impressed, but I wasn't with these type 2 patients. I realize they're type 2s, but you should have been showing a type 3 if you want to make your case. And then they also understandably referenced the article by Wold that I just got through showing you, and they mentioned that only 1 in 4 of these patients manifested pitting edema. Pitting edema. So therein lies my problem with using pitting edema to make your case that these patients don't actually have volume excess. And in fact, from their own article, they made the following comments. They referenced in Bruner's 1982 study, the fat layer has a soft consistency and does not allow pitting even over the tibia. Griegel described lipedema as a mucoid pseudoedema that stated that unlike what happened with cardiac and dystrophic edema, pressing over the lipedema did not cause pitting. And then finally, in this Rudkin American study, only 1 out of 4 or 1+ edema was noted in the pretibial edema, which means hardly any pitting edema. Now, do you find that surprising? I don't. I mean, let me go back here. Here's a lipidus limb, which, as Karen mentioned, it's fatty, it's soft. Why would you expect a lipidematous limb to pit? That's not what I typically see. That doesn't mean these patients don't have excess interstitial edema. It's just they typically are not going to pit because of this fat layer that they have. And then they utilized the following imaging studies to support their case that there's no edema in lipedema. And the first one here is a 2002 study. And via CT imaging, they demonstrated no excess edema in lipedema. And then in this 2020 MR study, there were no signs of edema in pure lipedema patients. But I would submit to you to the following references. In 2019, Krasinski's bioimpedance study did indeed document higher extracellular water in patients with higher stages versus lower stages of lipedema, and in patients with stage 1 lipedema compared with controls. That's likely your pure lipedema subset that they're referencing. And in this 2020 reference, perometry revealed significantly greater lower extremity volume in participants with lipedema compared to controls. To me, I would suggest to you that bioimpedance or perometry are more sensitivities to detect early excess interstitial edema. It's not necessarily going to show up on CT or MR. And let me give you some lymphoscintigraphy data to think about here. And Karen, you referenced this Polanyi 1995 study, 12 patients with pure lipedema. All of these patients displayed marked slowness of the lymphatic system. In this 2018 reference, 83 patients with pure lipedema, approximately half of them had abnormal imaging. And these abnormalities were detected in all clinical stages of lipedema, even the stage 1s, which are likely your pure lipedema patients. And finally, in this up-to-date 2020 reference, 19 patients with lipedema, 62% displayed abnormal imaging, which existed in all stages of lipedema, including nearly 1 in 3 with stage 1 disease, your pure lipedema cohort. Here's another 2020 reference, 54 patients, predominantly pure lipedema, 75% with abnormal imaging with characteristic tortuous lymphatics as seen here. So what does all this lymphoscintigraphic data mean to me? To me, it means that you have, even in your stage 1 lipedema patients, the substrate for developing excess interstitial edema long before they have clinical signs of classic lymphedema with fibrosis, et cetera. So as far as the evidence go, I'm just going to stick with there is edema in lipedema, and we'll talk about how this develops through one mechanism. Now, that being said, I would still say that the majority of lipedema patients you are likely to encounter in your practice are likely obese or even morbidly obese and have secondary lymphedema or secondary phlebolymphedema, also known as lipolymphedema or lipophlebolymphedema. And I'm sure most of you are familiar with the various staging of lipedema, that is 1 through 3. You sometimes will see a stage 4 out there, which connotes secondary lymphedema or lipolymphedema. In the standard of care guidelines, there's Dr. Herbst proudly referencing the article, this just a landmark article. We note that women with any stage of lipedema may manifest lymphedema, although it is more likely to occur in advanced stages. So we're going to stick with the 1 through 3 staging and not use this stage 4 criteria. And in fact, this advancement in lipedema or excess edema in lipedema is reflected in Karen's data from 2015, where she had edema in 50% of your stage 1s, 75% of stage 2, and 100% of your stage 3. So underlying or underscoring that comment on edema and lymphedema, especially, is more likely to occur in your more advanced stages. So that begets the question. So how do patients with lipedema develop edema? I like this reference from Documento de Consensus Lipedema. And it would be via orthostatic edema, venous insufficiency, which of course can lead to lymphatic insufficiency, and then just lymphatic insufficiency without venous insufficiency. Let's go through each one of these mechanisms. Let's start with orthostatic edema, because this is very important. And these are how the pure lipedema patients are more than likely manifesting their excess interstitial edema. And it's due to a dysfunctional veno-arterial reflux. So what is the veno-arterial reflux? This is the postural vasoconstriction reflex. Now, normally you have a decline in limb blood flow when the limb is placed in a dependent position due to a compensatory increase in the precapillary resistance. This lowers your hydrostatic pressure. And this prevents a loss of fluid in the extravascular space when the limb is indeed dependent. But if you have a dysfunctional veno-arterial reflex, this leads to egress of fluid into the extravascular space and subsequent orthostatic edema. And this reflex is mediated by neurogenic, specifically sympathetic mediated processes, and myogenic as well. So why is this slide important? We're looking at the pathophysiologic dilemmas of lipedema. And I would draw your attention to the fact that in the setting of lipedema, you more than likely have inflammation of your sympathetic sensory nerves, as well as a peripheral neuropathy of the small fiber type, collectively referred to as a lipidematous neuropathy. When you have a lipidematous neuropathy, that leads to a dysfunctional veno-arterial reflux, which leads to the characteristic orthostatic edema that complicates these pure lipedema patients. Now, here's a slide. Karen's referenced this. Lipedema has been recently linked to joint hypermobility through her landmark data, where at least half of these patients have a Baden score of greater than 5. So why do you care? Well, because probably a significant portion of these patients have hypermobile Ehlers-Danlos syndrome. What does that have to do with orthostatic edema in a pure lipedema patient? Well, it's as follows. 80 to 99% of your patients with Ehlers-Danlos syndrome or some type of hypermobility spectrum disorder have an autonomic dysfunction, 80 to 99%. And this is what leads to the characteristic leg swelling and discoloration, such as erythroacrocyanosis, as Karen referenced, in the legs after standing for only relatively short periods of time, as seen in orthostatic intolerance. And here's a good clinical example of that erythrocyanotic appearance that you can see in the lipidematous patient. And I would submit to you, when you see this discoloration, those patients probably have associated orthostatic edema as well. So another mechanism would be chronic venous insufficiency. I will quickly go through this because Karen did such a good job of covering this. I will reference the Ohio State experience where we had 440 patients referred in for manual lymphatic drainage. 12% of these had lipedema. All of them had associated lymphedema, but what was remarkable is half of these were actually phlebo lymphedema patients, and they had limbs that looked exactly like this. And I didn't find it that way. This is the highest numbers that have been reported in the literature, but considering the BMI was 48, I don't find this association surprising whatsoever. Just examples of phlebo lymphedema, if you will. So that begets the question, why does chronic venous insufficiency occur, Tony, in the setting of lipedema? Well, here's some likely pathophysiology. Lipedema, as we know through Karen's work, is a connective tissue disease. Varicose veins reflect abnormal dispensability and structural changes of connective tissue in the vein wall. And thus, lipedema patients are predisposed to varicose and incompetent veins. Let's go back to hypermobile Ehlers-Danlos syndrome. Why am I talking about this in the setting of venous insufficiency? Well, if you go, here's right off the website for the National Organization of Rare Disorders talking about Ehlers-Danlos syndrome, varicose veins develop at younger age than usual, are unusually widened and twisted veins. And then they list these clinical hallmarks of what happens in the setting of Ehlers-Danlos. And what do they have here? Orthostatic intolerance and POTS syndrome. What's that linked with? Orthostatic edema. And then finally note, venous insufficiency is listed as well. So I don't think it's hard, Tony, to come up with a substrate here where you have a patient with lipedema has this virulent combination of a connective tissue disease with an intrinsic vein wall defect in the setting of the pathomechanisms that underlie venous disease and obesity. I think that's a virulent combination that explains why half of these patients, when they're obese or morbidly obese, can have lymphedema and look just like that. And as far as why does lymphedema happen in the setting of lipedema? Well, again, Karen's advanced this connective tissue disease with lipedema, which may lead to dysfunctional elastic fibers that support your lymphatic vessels and subsequent dysfunction, capillary distortion dilation, leads to abnormal leakage and a dynamic lymphatic insufficiency. And finally, this tendency to increase compliance of the connective tissue disease, which facilitates the ability to hold on to fluids, proteins, and macromolecules. And then also this reference to this could actually be an underlying primary defect in your lymphatic vessels, which then leads to the secondary fat deposition. And this was also borne out in this study or this reference where they referenced a primary lymphatic angiopathy. And of course, chronic venous insufficiency can beget lymphedema, and then it's going to occur in the setting of obesity and all its associated pathomechanisms, which can affect the lymphatic system in the setting of lipedema. So to wrap things up, I would submit to you, as far as this protestation that there's no edema and lipedema, I will respectively disagree for the reasons I have presented to you. Orthostatic edema complicates the pure lipedema patient. That's what I see in my practice, and I think I've given you some rather compelling evidence that that's the case. And keep in mind, pitting is just not a sensitive finding for detecting edema in the setting of lipedema, because this fatty consistency just does not lead one to using pitting as a clinical marker. I showed you an abundance of contemporary radiologic studies which have documented the associated pure lipedema and edema, as well as lymphatic abnormalities. Pure lipedema is rare. Most of these patients you're seeing in your practice are going to be obese or even morbidly obese and have associated secondary phlebolymphedema or lymphedema. And then finally, let's just say, even if no edema existed in pure lipedema, would you withhold compression? And I'll stop there. I'll stop sharing my screen here.
Very eloquent and convincing. But I would still challenge you. Show me the data of that the prevalence of venous disease in these patients is due to the lipedema. I mean, I buy that there is some genetic, connective tissue.
What are you asking me, Tony? You're asking me to prove that the venous insufficiency is what leads to lipedema?
Yeah.
Oh, I'm just saying it's a concurrence. I'm saying It's an aggravating factor. I in no way think venous disease is necessarily the primary underlying factor, but it certainly complicates these advanced stages, especially when obesity is in the mix. But again, you got to consider this intrinsic
obesity too in there. Sorry. Go ahead, finish.
I finished. What did I say? I think it's a combination of, again, the veins being affected in the setting of obesity, morbid obesity, and all the associated pathomechanisms with this intrinsic defect that underlies with the connective tissue disease that these patients have. No, I think they're getting hit from, like Karen said, it's multifactorial. Their lymphatics are impaired, their veins are impaired.
And this is what the challenging thing is with these patients overall, with venous patients. I mean, for people that haven't thought about, lymphedema and lipedema contributing to the disease process and the clinical presentation, you look at weight, you look at calf muscle pump function, you look at, there's so many factors that affect the clinical presentation and their clinical signs. It makes it very difficult to get things separated and figure out what treatment modality is actually going to help them. Let's see. Any questions? If you want to go ahead, Paula. Great. There was a question on liposuction, but I think, Paula, you're going to touch on that?
Just a little bit if we have time, but I'm happy to answer any particular questions if we want to straight away.
How can we detect the early signs of fibrosis development?
I think the easiest way is just clinically.
Clinical, right?
Yep. Yeah.
And Rodrigo is asking, why is a disease that was described in the 40s, 50s is coming back to evidence now?
I'm sure Karen could wax eloquent on that.
Yeah, we've been looking at lipedema I have since 2006. So it's not new. I think it's just been difficult for some people to accept that women are not just fat, and that there is a unique type of fat that can become fibrotic and then become difficult to lose by diet, exercise, or bariatric surgery. And you see this clearly in the bariatric surgery literature, that there is fibrosis in fat tissue, and people with fibrotic fat tissue, it's harder to lose by bariatric surgery. But I think that's just kind of new stuff that people are finally coming to accept, that fat tissue isn't just a storage depot for fat. It's also an endocrine organ. But there's people who have been working on this for a long time. And in fact, lipedema has been alive and well in Germany while it was kind of quiet in the US. So I'm just excited that we're catching up.
Well, I would add to that is it's similar to like lymphedema over the last 5 years or so, 5 to 10 years has increased interest because, lack of education in many physicians. You can see even in the video from the beginning, patients go from one doctor to the other. Nobody had an idea. The average vein specialist now has a lot more knowledge on lymphedema than it did a decade ago. I think there's just the lack of really getting that education out there. Paula, why don't we go move ahead?
Yeah, actually, if you all are good with it, Dr. Herbst and Dr. Dean did a fantastic job of framing all of now what we may have to offer and what we can discuss for right now with lipedema therapy. Here are my disclosures. And really what I'd like to highlight for the physicians that are out there, nurse practitioners, those who are going to be referring to clinical therapists who can provide conservative treatment to help their patients, as well as then also the therapists out there, the actual treatment interventions that we can do to individualize the care for these patients, in particular also to tailor CDT. Dr. Dean did an excellent job for us. We need to make sure that we're looking at all the different levels of edema, including a stage 0, as Karen had mentioned, for lymphedema. And then also I'd like to highlight then the use of the pneumatic compression device for patients, as a segue from the awesome video that we saw to start off this talk. So here's our common impairments. What I'd like to highlight is, in addition to the hypersensitivity to touch pain issues that a lot of patients will run into, this patient population may also have a lot of joint deterioration and be complaining of musculoskeletal pain. And that may relate specifically because of the lipedema. We've just been talking about the frequency with morbid obesity, with lipedema, and also vascular issues. So as a therapist treating, we'd want to kind of keep those pains different and treat them appropriately. Then also we'll talk about the swelling, the balance impairment, the hypermobility that's been stated already, muscle weakness. I want to highlight a study here for us, and then also incontinence as it relates to pelvic floor weakness for this patient population, and then addressing the fatigue, stress, depression, mental health issues. If the clinician, if when evaluating the patient, you identify with this in the patient, if you're not the primary person to address those features, then it's the referral out. And last but not least, not to undermine the importance of addressing any simple obesity that also may exist within this patient population. Before I move on to the treatments, another element that is coming out more into the literature, one of my colleagues, Dr. Crescenzi, has been using MRI, sodium MRI, to be looking at what the sodium levels are in the tissue, and that's what I have depicted here. Increased sodium within the tissue is a hallmark for inflammation, and Dr. Dean highlighted a lot of it from inflammation potential within this patient population. Looking at the green triangle here at the top, that is a patient with stage 1 lipedema, and this sodium MRI is the colored MRI that we see here to the right. We're not used to usually seeing sodium. To the left, we've got the traditional water MRI. Higher levels of sodium in sodium MRI are depicted through warmer colors, the reds and the yellows. So as you can kind of see at the top, we've got a patient, stage 1, and just beneath we have a matched control. And interestingly enough, they are matched for age as well as BMI. And you can probably appreciate here, without my really pointing out too much, just the differences in the sodium elevations that we see within these two patient populations. And I'd like to underscore the fact that this is a stage 1 lipedema patient. That segues nicely from what Dr. Dean was just speaking of for inflammation and orthostatic edema and that sort. Lipedema treatment, one of the major components as clinicians, what we want to continue to just optimize is the patient's health, their overall health, their quality of life, and to promote for them individualized healthy lifestyle. That would then entail using precision medicine for that person and tailoring it to their therapy to the needs that they have, as well as their personal desires. Halk and Dampster in 2017 nicely put these pillars of conservative treatment for patients with lipedema, highlighting the need to have graded exercise tailored specifically to the patient, as well as healthy eating that would be sustainable for life, addressing edema management, and also providing supportive measures to appropriately and fully treat this patient population. So now, where do we begin? We've got potentially a lot of different impairments that were mentioned, and at what point do we need to start with one and go to the end? Is it hierarchical? And what I would like to surmise is that really we need to start all hands on deck, and to not waste a single visit, to make referrals as we need, and all across the board to be addressing these interventions that we have as conservative treatment interventions for our patient population, highlighting the use of CDT, the more overt signs of lymphedema that the patient has. So let's start then with the manual therapy. We'll work left to right here briefly. Tissue mobilization is a wonderful technique that skilled clinicians who are great with their hands can utilize. And a lot of research that we have down here, Dr. Herbst as well has contributed to this, to show that manual techniques help to reduce pain. And we've been talking a lot about pain, this lipedema pain, not the musculoskeletal pain. I'm talking the hypersensitivity to touch. In addition to, we use manual techniques for remodeling the tissue as well as decongesting. And we know a lot of people on the call know MLD is utilized to reduce lymphedema. And Dr. Dean did a great job of kind of talking about a whole gamut of individuals all the way down to stage 1 potentially can present with impaired lymphatics. But in addition to that, manual lymphatic drainage is a stimulation of that lymphatic system, and it uptakes our waste products. So if we have a lot of cellular waste and we've got a lot of pain and we're kind of mobilizing tissue, one of the ways to kind of help reduce pains is actually to incorporate manual lymphatic drainage. It just may not look exactly the same as another type of secondary lymphedema or a primary lymphedema, especially in the setting of a patient who has stage 0 lymphedema or more complaints of orthostatic edema. So that's how you kind of tailor it. So I'm not going to go into this because Dr. Dean did a fantastic job and there's a lot of question marks out there about the swelling. But as a therapist, we're going to just treat what we see. So if our patients, we have a great history with them, we ask a lot of questions as we're going through the therapy process, we can keep making sure we have it all right. We just need to meet the patient where they are. If there's orthostatic edema, address it. A lot of times patients with lipedema and having overt signs of lymphedema, but even more of these subtle orthostatic edemas, the compression will look very different or can look very different than our traditional other secondary lymphedema patient population or our primary lymphedema population. Containment requirements could be less. Micromassage might be more than sufficient. A flat need for compression garments, we might really need a lot more of this flat knit because of the angles and the curves that the patients present with, where we want to make sure that we're not going to be providing a patient with a type of compression that could just kind of roll in and create a tourniquet. So then a lot of times these patients need full coverage. And if we have a lot of angulations that happen at the upper thigh, the thigh highs are not really probably that appropriate. So we might be needing to look as clinicians using the capri and the knee high approach. But it's just going to depend on the individual. So we would be addressing through therapy balance and gait impairments. If you're a referrer to a clinician, these could be some things that you would expect that clinician to be a therapist to be able to help. And I want to just highlight that balance and gait impairments can be addressed in water and land. So both of them can work nicely. It's just going to kind of depend. But water is a great place to also be addressing these balance and gait impairments and doing static, dynamic balance retraining, eyes open, eyes closed, depending upon what the patient needs. Certainly gait training. And I'll highlight the joint proprioception. We want to just make sure that they're able to kind of improve upon any impaired joint proprioception based on our assessment. So now I'd like to segue into this hypermobility that we've heard about already today. We want to educate the patients now. So they're hypermobile. Great. What do we do about that? We don't really want them to continue to function in such a manner. We need to teach them that that's not okay or why it's not okay, especially if they're not having pain from a prevention standpoint. Certainly if they are having pain and they've got even now joint deterioration because of that hypermobility, we'd want to be addressing it as well. And then I just want to highlight the appropriateness for using supportive shoe wear then to support anything that's happening at the foot. You may be able to appreciate this patient. She's got stage 1, type 3. The subtle nature of needing a shoe, supportive shoe then for her right ankle. And then also her tendency to lock out, even though she didn't go into hypermobility, she would lock out in stance, and she just needed a simple retraining about that. Muscle weakness. This is a wonderful article that was published in 2017 for the Journal of Lymphedema. And I look forward to future articles showing what's happening in this patient population as compared to persons with obesity that do not have lipedema. So what this article is kind of highlighting here is patients with lipedema compared to matched obesity had a less than predicted quad strength. So I say less than predicted. So let's assume 100% is the predicted amount. This patient population, the lipedema was 70%. So they didn't meet that predicted amount. And then the obesity group was over the predicted. So they were a little bit over 100, 103.6%. And a lot of times with our lymphedema population, they're carrying around weight. And so they actually have pretty strong muscles that are underneath. underneath. What's interesting is that might not be the case with our patients with lipedema as well. And so teaching them appropriate strength programs are really important. Really important to ask the patient a difficult question. What's happening? Is there an incontinence situation? It's very common within female population with aging, so it's important for all women's health to be addressing this question with our patient population. But with lipedema, I think there's more to be added here about the frequency of incontinence with this patient population. What I have listed out here is just a very simple protocol looking at doing Kegels on a regular basis. And to highlight to the audience, we need our patients to be doing an average of 50 to 70 Kegels per day for an average of 20 weeks to start to see some functional gains. That's a commitment, but it's a simple exercise. It's just a training piece. It's similar to how we do postural retraining, and it just requires thinking about it initially, and it becomes a habit later on. So moving on to tailored exercise programs, we got the LAND. LAND is wonderful for all of these components: strengthening, flexibility, balance, and conditioning. And I wanted to underscore that pelvic floor one more time. And the key here is to get what the patient enjoys doing and has access to, just to encourage long-term carryover after they're finished seeing a clinician for their well-being. I want to underscore again the benefits to water. Some of our patients, they really don't do well on LAND. Pain can be a huge factor behind that initially as well. Water is a wonderful gift to patients that they have access to it. And so everything you do on LAND, essentially you can do in water. Maybe there's a few modifications that are needed, but balance exercises, dynamic walking, dynamic workouts are all appropriate in addition to just walking in the water. Self-help treatments, everything I just talked about as clinicians that we would be doing all throughout the course of treatment. The goal would be that the clinician is teaching the patient in between sessions on what she can be doing for herself. And if there's a caregiver needed, there's already caregiver training. So it doesn't happen at the end of therapy sessions or the course of therapy. It happens all throughout concurrent. And I'd just like to highlight the use of the pneumatic compression pump, a wonderful way to continue to stimulate the lymphatics to reduce swelling. And also there's opportunities to address pain. And in particular with the Flexitouch, with the unique mechanism of being able to modulate and adjust the amount of pressure. If we've got a patient that's got more hypersensitive sensitive legs at the time, lower pressures are important, whereas the traditional type, those pressures are a lot higher. Also, just to point to the left here, the Flexitouch Plus has the mild dynamic pressure where it's got the isolations of 1 to 3 second intervals where they're delivering increased pressure and then reduced pressure over time. So with the Flexitouch system, as compared to the other types of pneumatic devices that are out there, it's really valuable to our population so that when they're treating themselves at home, they can be trying to mimic what a therapist is doing in the clinic with manual techniques. And that's really more through this work and release phase, as you can see on the top, in the top left, we've got that work and release options versus compared to the other types of pneumatic devices where it is that press and hold to higher pressures. The other piece that's really beneficial with the Flexitouch Plus is treating the trunk and also that bilateral leg treatment at the same time. Surgeries, we'll have to go more into that maybe with Q&A because I know I'm over time. Therapists have such an important role pre and post surgeries, whether it be that weight management, getting them moving, and also that liposuction and manual treatments, helping patients with compression, especially if they were not needing that before their liposuction procedure, to kind of help them through those initial phases, and also to make those referrals that are needed as we were talking about, which, here we go, last slide, that multidisciplinary approach. Any one of us at any point in time can reach out to the other clinician that can provide the appropriate care for that patient to optimize their quality of life and not drag out reduced function, increased pain longer than it needs to be. If we get the patients where they need to go when we have a multidisciplinary approach, the patients do so much better, so much faster. And I believe they actually have a better quality of life and they feel appreciated by their clinicians. All right. That's me. I wrapped it up. Thank you so much.
Thank you, Paula. Great. So let's get through some of these questions. All right, Lisa's asking, is pain always present in this population? I've identified women who present clinically with lipedema but have no pain or bruising. Steve, you want to take that? Or Karen?
So we published a questionnaire study on liposuction, and I think it was 11% of those women did not have pain. So there's this concept of lipohypertrophy, where you have tissue that is increased in the same distribution as that of lipedema, but they don't have pain, they don't have edema, they don't have bruising. And I don't have an answer to that. I don't know, we don't have the tools to differentiate between lipohypertrophy, if that is even something, and lipedema. But, people have different pain sensitivities. There's some people that say, I really don't have any pain, but you can see that they've got just a lot of pathophysiology going on. So
yeah, and that's
we need to collect more data on that.
And that's with all disease. I mean, even with venous disease or anything, I see patients with humongous varicose veins and completely asymptomatic.
Yep.
So obviously, there's the classic findings for diseases, and then there's variations in presentation.
What I also kind of noticed with this population where they don't have pain, there's oftentimes a lot of easy bruising. And also when you touch the lipidemus area, it's oftentimes cool to touch, and the patient or their loved ones oftentimes know that it's just a little bit cooler to touch than the rest of the skin area.
When is liposuction offered or indicated?
Well, none of us are surgeons on this panel, but we usually—
When do you send patients over to—
We usually recommend liposuction for patients who have undergone all the conservative therapies. They've tried multiple diets. They've exercised more than I will ever exercise. They wear compression garments. They're using their pumps. They've seen MLD therapists, and still they have a lot of pain in their tissue. They're struggling to control their swelling, and they are having trouble with mobility. And so mobility issues, pain issues, and just non-responsiveness to conservative therapies are good reasons to look into lipedema reduction surgery. And I think it can happen at any stage.
Is there a special diet or any thoughts about the keto diet for these patients?
I recommend keto diet to a lot of my patients, but some of my patients don't tolerate it, or they just don't like it. They can't do it for one reason or another. So I think I like to personalize the diet to the patient. What do you like to eat? And we tell them to avoid processed carbohydrates, foods with chemicals in it, and to try and eat whole foods as much as they can.
To sort of underscore these last two questions as well, we want it to be sustainable for life. So a lot of people do extraordinarily well with the keto diet, and I'm amazed by it. And it's turned my head in that direction to understand it even better. But with that, there's been a lot of ladies where that's just not something that they're able to do, but they do a lot of healthy eating, cleaner eating, and reducing the eating of inflammatory foods for their own body. If I could cycle back for liposuction as well, sometimes a very good appropriate person is where they've already done their conservative treatments. They've had success with it in the point that they've increased their movement, they've increased their strength, they've got a handle on a lot of those features. And now we still have this lipedema, and they've reduced pain, but they have this lipedema tissue that sort of just gets in the way, balance, gait, their general mobility, and also psychosocial components. And we've had some wonderful successes then after that, where they're bouncing up and down stairs and they can't even believe it. So that was a recent story that a patient told me, that her daughter could not believe that her mom just ran up the stairs.
Now, there was, I think, Karen, you mentioned hormonal effects happening before the onset of lipedema. Any role of hormonal therapy?
I've had a lot of patients with lipedema on the birth control pill, and they seem to do okay. So what I recommend is that you just try and keep hormones that you would take by mouth or by a patch or topical to a minimum. So you're not using large doses of estrogen or progesterone, and that you're trying to balance it. I haven't seen a lot of women with lipedema just on estrogen, because the thought is that, estrogen is playing some role in the development of lipedema, but really we just don't have a lot of data on it, except for the study on a gene that came out of Italy, where an enzyme has a mutation in it so that progesterone is not metabolized well. So higher progesterone levels are known to increase the growth of fat tissue. And that's really our only piece of data that we have.
Thanks, Karen. Steve, when would you send somebody for venous intervention for CVI when they have underlying lipedema?
Venous, well, I think we've already kind of addressed that. Karen did. I would just say you're looking for that. First of all, I would not submit them for venous intervention if their BMI is above 45 based on the recent data. I would say that number one, they have to lose weight first, if possible. And then number two, you're looking for the one that has something you can localize. Unilateral symptoms, I think, in the setting of a unilateral refluxing GSV would be a prime target. But on the bilateral ones, that's a tough call. That really is, because again, my experience has been that their even improvement they have is short-lived, and it doesn't seem to make a huge difference overall.
And I'm going to wrap up here because we're a little bit over. We got a lot of questions, but I think we got most of the questions here.
I'll tell you one thing I liked in that video. We mentioned the sense of fullness in her legs at the end of the day. She didn't really see edema, but fullness. It's back to that concept. I just think you don't necessarily are going to have pitting edema. The interstitial edema is there. It's just not going to pit, and it's manifested a lot of times by fullness. I keyed right into that when she said that.
Well, this one's for you specific. I have a patient with CVI and lipedema symptoms from the knee to the pelvis, and CVI from the knee to the foot. What type of compression would you recommend?
Oh, loaded question. And ultimately because there's so many components to answer in this question. And I put my foot in my mouth before when I give an actual amount. And then an appropriate question a therapist might say is, well, can they put that on? Or something along those lines. I don't know if it's coming from a physician or if it's coming from a therapist, but really what we're looking for is containment. So if you can go with the least amount of what's needed and it appropriately contains, and also I'm going to add on to this, the patient needs to be able to don and doff and or with a caregiver, then we've got a good mix. If we just kind of prescribe and say, you must do this and this only, oftentimes that's where we meet a lack of compliance, and it's not really a part on the patients. It's not a fault of the patient. It's just that we as clinicians need to just kind of modify things that are going to actually work with the patient. So I didn't really give an answer because I'm not able to give an answer with those details.
Yeah. Well, I want to thank the whole all-star team here on lipedema. I want to thank Tactile for putting this together, and have a good night, everybody. Thank you for taking part of this, and visit us at the Tactile Medical Education website to get a recording. I know there's a lot of questions about some slides. You'll be able to download or watch the recording of this at your leisure. Have a good night, everybody.
Good night, Roy.